Thank you, Laura, and good morning, everyone. I'm very happy to have this opportunity to talk to you today about medSask, and I have to thank Erin for her pitch for us earlier today. Medication therapy is becoming increasingly complex, and keeping up with the medical literature and latest development in drug therapy can be an overwhelming task. Since we're focusing on seniors today, did you know that nearly 2/3 of adults aged 65 and older are taking 5 or more prescriptions? And that more than 40% of Canadians age 85 and older are taking more than 10 drugs? With the number of seniors expected to double in the next 25 years, healthcare providers will be called upon to manage a multitude of medication therapy issues. At medSask, we specialize in researching and analyzing drug-related problems. We think our service could be useful for many more healthcare providers than are currently using it, and suspect that this is because they're not aware of the service. So in this presentation, I'll describe the services offered by medSask, give specific examples of the type of information that we can provide, and show you how to access the service. So as Laura mentioned, we work out of the College of Pharmacy and Nutrition at the University of Saskatchewan, and our office is in the beautiful new Health Sciences building. From here, we operate 2 toll-free medication information lines available to healthcare providers and consumers anywhere in Saskatchewan. The lines are open 8 a.m. to midnight weekdays, Monday to Friday, and 5 p.m. to midnight weekends and holidays. During that time, calls are received and responded to personally by medication information consultants. Queries can also be submitted at any time via email or by going to our website. We're funded mainly by grants from the Drug Plan and Extended Benefits Branch, which is an arm of the Saskatchewan Ministry of Health, and by the Saskatchewan College of Pharmacy Professionals. We receive in-kind support from the College of Pharmacy and Nutrition in the form of office space and supplies. Then we rely on donations from pharmacies and pharmacists, as well as fee-for-service contracts for various drug information projects to meet our budget. We're supervised by an advisory board consisting of representatives from all of our major stakeholders. The board meets once a year and helps us to meet our goals and assists us in setting new priorities. Our director is a faculty member of the College of Pharmacy and Nutrition, and myself and the other medication information consultants are Saskatchewan licensed pharmacists. So our ultimate goal is to promote positive drug therapy health outcomes for Saskatchewan people. And our objectives on the professional line are to provide healthcare providers with objective, current, evidence-based information on drugs and drug therapy, to take part in continuing education programs in the province, provide experiential training for students, promote interdisciplinary collaboration, and to participate in drug information research. Last year we had over 3,000 queries on the professional line. 80% were from pharmacists, but we did receive 10% from nurses. These were mainly nurses that work in public health and the travel health clinics. And 3.5% of the questions were from nurse practitioners. For over 80% of the calls, we were able to provide an answer the same day the call was submitted. So we receive questions on a wide variety of topics. These are the statistics from last year. Administration and dosage was at the top of the list, followed closely by questions on compatibility, formulation and stability, and therapeutic use or indication for the drug and drug of choice. Drug interaction, adverse reaction, and questions on drug use during pregnancy and lactation are also frequent questions. So now let's have a look at a few specific examples of questions that we received on the professional line last year. To be consistent with this morning's theme, they all involve seniors with diabetes or cardiovascular disease, or as commonly the case, both. So in the first example, this particular question was submitted by a nurse practitioner. The patient is a 75-year-old female with diabetes and was having trouble controlling her blood sugar levels. So the nurse practitioner decided that it might be helpful to switch her from the Humulin to a basal insulin, and wanted to know what dose of the longer-acting insulin she should be switched to. So the recommendation when changing from once-daily insulin to a basal insulin is to start with the same number of units that the patient was receiving in the once-daily injection of regular insulin, in this case, the Humulin N. And as well, since the basal insulin would be at greater than 0.5 units per kilogram, the consultant also suggested they might want to consider mealtime insulin as well, too. In the second example, excuse me, this was a question from a pharmacist who was doing a medication assessment for this patient and looking at his diabetes medications, wondered if it might not be possible to simplify his regimen by discontinuing the pioglitazone and doubling his gliclazide dose. The response was that probably this wouldn't be a good idea. In a study which compared triple therapy with the pioglitazone versus placebo being metformin and a sulfonylurea, there was a significantly greater decrease in HbA1c in the patients on triple therapy. As well, there was a significantly lower progression to permanent insulin use in the triple therapy group. And the other concern with doubling the dose of the sulfonylurea was that it would increase the risk of hypoglycemia without really giving as much benefit as you would expect from doubling the dose. So in light of this therapy, we didn't recommend, we recommended continuing with triple therapy rather than discontinuing the pioglitazone, unless the pioglitazone was causing unwanted side effects. The third example involves drug interaction. This again was a question from a pharmacist. The Saskatchewan formulary states that canagliflozin should not be combined with DPP-4 inhibitors. And the pharmacist had an order for this combination and wondered what the risk was with the use of these agents together. This patient had a number of different medical conditions as well as type 2 diabetes and was on a large number of medications, 12 altogether, I believe, which unfortunately isn't atypical for patients with this age with multiple comorbidities. So in investigating this interaction, there were no reports of any harm with the combination. However, they're not synergistic or even additive in their effect on HbA1c. Together, they only produce a slightly greater reduction than either agent alone. So it's not a cost-effective combination and therefore not recommended by the drug plan. The fourth example involves a potential adverse effect. This again was a question from a pharmacist. The patient's family was wondering whether the patient's recent loss of control of his blood sugar levels could be due to either of the new medications he'd been started on recently. He'd previously been doing quite well on metformin and glycoside, was started on dutasteride 3 months ago for prostate enlargement, and then started on a statin 1 month ago. His blood glucose had been increasing since probably 3 or 4 months ago, and they hadn't been able to control it even with an increase in his metformin dose. So the question was, could it be either of the new medications causing the problem? Well, there's no information that dutasteride could affect blood glucose levels. Rosuvastatin and the other statins, however, have been associated with increases in blood glucose. However, in this case, the rosuvastatin was started just a month before this inquiry was made, and in that case, the blood glucose had been increasing at a time before he was started on the rosuvastatin, which makes it unlikely that it would be a drug-related problem. A1C on average is increased by about 0.3% on a statin versus a placebo, but the cardiovascular benefit of the statins in general will outweigh the risk significantly. Because it can be a dose-dependent effect, though, keeping the statin dose to the lowest effective dose for the patient's cardiovascular risk is recommended. And there doesn't appear to be any difference in this effect between the different statins. However, in this case, because of the time frame, we didn't think that the patient's problem with his blood glucose levels was related to the statin. This is a question involving the non-pharmacological ingredients in a product. A patient with type 2 diabetes brought in a new prescription for cholestyramine. The cholestyramine comes in 2 different preparations, one with sugar and one without. In this case, the pharmacy only had the brand containing sugar on hand, and the package unfortunately stated that it contained sugar but did not say how much. So the question was, would the amount of sugar that could be in this product affect the patient's blood glucose control? And would it be a problem if they used the regular product tonight and for the next day until they could order in the sugar-free formulation? And the pharmacist also asked us to check on the dose of this to be used for C. difficile. Since this is a non-traditional use for this product, it's usually used to absorb cholesterol and prevent its absorption. So the recommended dose in this instance to treat C. difficile is 1 packet 3 to 4 times a day. And we were able to find a resource which gave us the amount of sucrose per package, which was 4.6 grams. And according to the diabetes guidelines, up to 10% of the daily intake of sucrose is considered acceptable. Therefore, the patient taking 1 or 2 doses of the cholestyramine product was unlikely to be a problem. And the last example involves natural medicines, and we do get quite a few questions about these. This was a call from a physician whose patient had asked about the benefits of taking milk thistle and dandelion leaf or root for cirrhosis. The patient has type 2 diabetes and is on metformin, furosemide, B12, and B6. So when checking into this, we couldn't find any studies that looked at the benefit of dandelion for hepatic function, other than anecdotal. There have been a few studies done for milk thistle. However, the results were conflicting. So at this time, there isn't enough reliable evidence to recommend the product. Of course, on the other hand, we're always concerned about the safety of these products as well, too. And there were no reports of any serious adverse effects with either the dandelion or milk thistle. One potential problem, the milk thistle can lower blood glucose in some patients, but since this patient was just on metformin, which seldom causes hypoglycemia on its own, it's unlikely that it would be a problem. So if the patient felt quite strongly about using the medication, we thought it wouldn't be a problem for them to try it. So the general public can call in independently to the consumer line to ask questions about prescriptions, over-the-counter medications, or herbal remedies. We don't take questions, usually we don't take questions, we do make some exceptions, but on illegal substances. When we do get calls about those, we generally forward them to the Alcohol and Drug Addiction Services because it's a very specialized area, and if the caller is at the point where they're ready to seek help for a problem, then we want to connect them with the association, which can start the process as soon as possible. So again, our mission is to promote optimal health outcomes from drug therapy. And on the consumer line, our goals are to provide healthcare consumers with timely access to objective, current, and evidence-based medicine on drugs and drug therapy. A lot of consumers will get their health information, or at least supplement their health information, by going to the internet. So when they phone us, we're able to help them sift out the good from the not so good information and maybe direct them towards a more reliable site. We'll also direct patients with serious adverse reactions and other problems to adequate medical follow-up. And we do educational and training programs for a variety of consumer healthcare audiences. We document all our calls, so we do have a quite extensive database of information which could be used for identifying drug-related problems in the community. Now, I want to emphasize the consumer line is intended to supplement, not to replace the advice from healthcare professionals. In fact, much of the counseling that we do with consumer callers is centered around reinforcing the need for consumers to follow their healthcare providers' advice and helping them to find ways to do this. We have quite a close working relationship with the Healthline, which is the nurse's 24-hour advice line. When the nurse receives a call from someone that has a drug-related issue, they will refer the patient to us, particularly in the evening. In fact, up to 80% of the calls we receive during our evening hours are those that have been redirected from the Healthline. Altogether, we received over 4,800 calls from the general public, and these were on a wide range of topics and severity. Most of the calls we receive are not serious, but about 10% we rate as potentially serious. And for those callers, we'll give them what information we can immediately and then refer them to their healthcare provider as soon as possible. We get a few very serious calls, and these we will send them immediately to the emergency department or forward them to the poison control line. So again, a wide range of calls. We do see a bit of a difference between those that come in the evening and during the daytime, and that's a difference we attribute to the difference in age between the callers that frequently call during the evening or during the day. The evening callers tend to be younger and are calling about dosages for children and also questions on pregnancy and lactation as well. Whereas during the day, we have some regular callers, seniors, who will call us every time they get a new prescription and get all the information that they can on it before they go ahead with it. So some examples of the questions we do get from the general public. In this particular case, it was a 65-year-old lady who had just been diagnosed with diabetes. She had a prescription for metformin. She hadn't started taking it yet because, first of all, she doesn't really like to take pills. And second, she'd read the handout that came with the medication. And what was this lactic acidosis? It sounds pretty serious. So the first thing that the consultant did was to assure her that the metformin is the first choice when starting therapy for diabetes, and went through all of the benefits of metformin compared to the other anti-diabetics, and assured her that the most common side effects were gastrointestinal, which could be uncomfortable, but usually were not serious, and that could be managed by adjusting the dose of her medication. Then went on to tell her how extremely rare lactic acidosis is, and that it's more common in people that have other contributing medical conditions, particularly reduced liver or kidney function. And this is the type of question that tends to come in later in the evening, patients calling about their insulin dose when they're not able to reach either their clinic or their pharmacist. In this particular case, this patient had been adjusting his insulin and been having problems with hypoglycemia. So the evening before, he had taken 25 units and had a symptomatic low at 4 in the morning. Tonight, his blood glucose is at 7, and he's wondering how much insulin he should take. Now, this patient has had diabetes for a number of years and has, as you can see, has developed some of these serious complications that result from long-term diabetes, having had surgery on his right foot and a left foot amputation a few months ago. And he's on a number of medications as well as his NPH insulin. He was only using the NPH insulin. So our goal with questions like this is to give the patient short-term help them get through the evening and the night, and then advise that they see their physician or their diabetes educator as soon as possible to make more permanent adjustments to their insulin schedule. So the concern is always short-term is hypoglycemia rather than hyperglycemia. So the medication consultant advised that the patient take a lower dose of the insulin this evening and then check his insulin or check his blood glucose the next morning. And the caller stated that he does wake up several times during the night and checks to make sure that he is not too low. Another insulin question, and this one comes up not too frequently, but enough times, where patients confuse their two types of insulin. In this case, it was an elderly lady who phoned us just after she realized that she had given herself the Lantus dose, but using the Humalog instead. So in this case, of course, we're quite concerned about hyperglycemia. She wasn't willing initially to go to the emergency department, So the consultant ensured that she had a fast-acting source of glucose on hand and knew when she should use it, and advised that she have a snack with what she had on hand, something containing carbohydrate and protein, and informed her she should check her blood glucose every 15 minutes. The consultant called back after an hour and a half. At this point, the caller had already taken 4 Dex tablets. She'd had her snack with what she had on hand. Her blood glucose levels were dropping quite rapidly, and she wasn't feeling very good. So this time when the consultant suggested she call the ambulance, she agreed to do that. We called back the next day to see how she made out, and she was at home, but she had spent the night in the hospital, was feeling much better, and appreciated the help that she had received from the consultant. And another supplementary health food question, and we got quite a few of these from consumers. The patient's wife called us in this case, and I didn't mention, but 80% of the callers on the consumer line are women rather than men, so which points, I guess, to women still taking that responsibility as the caregivers for the family. But anyway, reading the leaflet that came with the coenzyme Q10, she noticed the caution about using it if a patient is on a blood thinner or high blood pressure medications. So she asked us to check his medications to see if there were any that would interact with the coenzyme Q10. The patient is a 68-year-old male, and he'd had a heart attack 2 weeks ago, so he was on all of the recommended post-MI meds, including 2 antiplatelets, the Brilinta and ASA. So the interaction between coenzyme Q10 is actually with the vitamin K antagonist anticoagulants, not the antiplatelets. So there wasn't a concern with using it with the ASA and ticagrelor. It can lower blood pressure, so we cautioned the caller that her husband should monitor his blood pressure, and if he is noticing any episodes of symptomatic low blood pressure, to check with his physician. Possibly the doses of his medication might need adjustment, or at this point they might look at the value of taking the coenzyme Q10. And the last example, and this is a good example of how sometimes it's difficult to convince people to continue taking their medications when they can't see that they're really helping. This lady was on metoprolol 12.5 twice a day for atrial fibrillation, but she wasn't sure whether she needed to keep taking it because she didn't find that it made her feel any better. So of course the answer was yes, it is very important to continue taking the medication. And the consultant went on to tell her why it was important, not only to reduce the irregular heartbeats, but also to prevent a potential clot forming as a result of those arrhythmias. And that even though she was feeling better, that was actually a sign that or feeling good, that was a sign that the medication was working well for her. So although our core responsibilities at medSask are to operate the two telephone lines, we do also post information on our website as well. And we have information both at the professional level and the consumer level. So we do periodic reviews of relevant topics and post them under our newsletter heading on Drug News. The most recent one was actually on the place of the SGLT2 inhibitors in diabetes. And if we find that there are questions that are being asked frequently, we'll post them under the hot topics. The most recent one here was on switching between the different diltiazem extended release formulations. So there's a number of different generics and a number of different extended release formulations, and they're not necessarily all bioequivalent. So if you're interested in that, just go to our website and you can look it up under our hot topics. And on the consumer side, we also have frequently asked questions that we post quite often. The most frequent one that we posted, and I think it was after I printed these, was on head lice resistance and which medications to use if the recommended OTC product, permethrin, is not working. And there's several other topics on there as well. Recently, there's been some information about foods that might be helpful in preventing Alzheimer's, so we did a bit of a write-up on that. And we're also always happy to do continuing education sessions, as well as taking presentations and posters to professional conferences and exhibition booths at consumer healthcare conferences. We work with a number of other healthcare organizations, as well as I've mentioned the Saskatchewan Healthline. And we do work with RX Files as well too, researching some of their topics for their drug comparison charts, which are an excellent resource, as Erin has mentioned, as well as their Jerry RX Files. And they are available at rxfiles.ca, or if you're not able to access it there, you can also go through SHRP as well. And all healthcare professionals in Saskatchewan can log into SHRP. And I would recommend, if you haven't done it, have a look and see what's available there, because this program is operated out of the U of S library, and it gives you access to a lot of the great medical resources available there. And then we work with a number of pharmacy organizations as well. We do an annual update of the Lung Association website formulary. We work with the Medication Assessment Center at the University of Saskatchewan. And this, if you're not familiar with it, is a pharmacist-operated medication assessment clinic designed for people that are taking 5 or more medications, or who are on who have complex medical conditions which they have to take medications for. Any healthcare professional can refer patients to the clinic, or people can self-refer, and there's no charge for it. And then, of course, I've also worked with the College of Nursing in a couple of these e-learning seminars. And this is a list of our current staff. Our permanent staff are in the Saskatoon office, but you'll see that we have people working for us at various different places throughout the province. Through the wonders of technology, they're able to log in and use all of our resources, and we can forward the telephone line to them. So these people, usually, most of them have regular daytime jobs at a pharmacy or in hospital, and they really enjoy fielding questions on the information lines because of the wide variety of questions they get, and the challenge of the different people that they get to talk to. And this and the following are probably the most important slides in this presentation. This is how you can access the Medication Center. On the healthcare provider line, we have a 1-800 number which is available across the province, and then the other number is our local Saskatoon and area number. You can email as well or go to the website and fill out the form there. And on the consumer line, there is a separate 1-800 number as well as the Saskatoon area number. If you phone the wrong line, it's really not a problem. We're in the same office and we can just transfer between the lines. And again, consumers can email in as well too, or fill out the form on the website. If you would like flyers or magnets or pens to give out to your patients, feel free to call us and we'd be glad to send any of these out to you. So in closing, I would really encourage you, if you haven't used the service, to try it out and see what you think. And if you like it, please spread the word and give out our information to your colleagues and patients.